Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Today, I'm very lucky to be joined by Professor, soon to be Emeritus Professor, Bill Vicenzino. Bill, thanks for coming on today.
Oh, thank you. Thank you very much, Jack. And especially since you, without training you beforehand, you got my surname spot on. So you're off to a winner.
Well, if you listen to some of our other podcasts, you'll notice that that's not always the case. So, Bill, to give some context to this conversation, can you introduce who you are, what you do, and your current role?
Yeah, so my current role, I'm retiring in 2 weeks' time, but my current role is I'm a teaching and research academic at the University of Queensland, which basically means I share my work, teaching and research. How I got here, I graduated as a physiotherapy some 44 years ago, and I've done the bachelor's and graduate diplomas and masters in magnificent sports. And in 2000, I got my PhD at UQ. Since then, I've earned something like 30 million or a little bit more in research grants, published over 400 research papers. I know these data because I've had to apply for a grant recently. My field weighted citation index is 2, which means I get, on average, cited twice as much as the field. So that's kind of my research side. We'll talk more about what I do in my research. I'm at UQ. I'm a director of the master's program, the specialty master's program in sports and musculoskeletal physiotherapy. I run a research unit and all the things you expect an academic to do. So I'm essentially academic. I started off in private practice. I did a year in hospital and then been in private practice since then. So I'm a musculoskeletal sports orientated private practitioner, clinician scientist, you might say.
But on that note, you mentioned about the training you've done, which includes doing, you said your master's in manipulative therapy, correct?
Yeah.
From what I understand, that doesn't actually exist anymore. And this is actually something I want to discuss because I feel like you would have seen a lot of the changes in physiotherapy. And one of the transitions is the emphasis or lack thereof potentially on manual therapy. And I think that's even reflective of the fact that there is no such thing as a master's of manipulative therapy there. So I'd be interested to hear your thoughts about that and looking at the changes within our profession.
Yeah, how long have we got? So just my timeline I reflect on this quite a bit because we do find ourselves in a place where manual therapy is being pillared or whatever the word is. So when I graduated, like there was electrotherapy, exercise, and just the start of the manual therapy movement, like the Maitland movement and McKenzie and Mulligan came a little bit later on. You had the Carlton Bourne in Europe. And basically there are a lot of strong figures that really pushed manual therapy as the cure-all and poo-pooed essentially electrotherapy and some of the exercise too. They weren't big on any of that. They were big on hands-on. And I think, so we had a big curve in that. In my early professional career, decade and a half or so, was very steeped in that. So I did my training in sports and manual manipulative therapy in Curtin and Perth. And so, we had that boom. And I think as I push back against it, we've got some very strong figures that got bent out of shape towards the last decade and a half that now go more towards exercise, and they're appealing to the younger generation who do a lot of their communication through social media and pick up things there. So these guys have become very strong in that medium. And so there's a push against it, so much so that you do get a push against manual therapy. Just to put a line under the thing that you mentioned about manipulative therapy, the profession decided about time flies, a little while ago that maybe you shouldn't have a degree that's based on a modality, but it should be more in line with medicine, and musculoskeletal physiotherapy was decided. But New Zealand, I think, still have kept manual therapy. I was there for I think it was their 50th Minute Therapy conference, and I was the keynote. And they were still arguing that they want to keep manual therapy as their name, not musculoskeletal. So it was kind of interesting. But international, we've gone to musculoskeletal physiotherapy. And I think it's, it is a bit like coming back, the pendulum swinging back to a more moderate, it's exercise and it's education as well as manual therapy, as opposed to the early push was strongly, it's osteopathic, chiropractic, manipulation type therapies. So it's a bit of I see it as a pendulum swing, and I think it's always strong voices, generally men, that push it one way or the other. So it's quite interesting. So I did mine in manual therapy, but our degrees in Australia are now called musculoskeletal physiotherapy. Yeah.
But in my observations, I feel like it's swung almost completely the other way, because there is actually, like you mentioned, there's some very strong voices against manual therapy. And I actually see that also in the curriculum. Like I mentioned before we started, I do some teaching in the undergraduate program at Lateral University. And in fact, actually, soon I'm going to be teaching some of the high velocity joint manipulation, spinal joint manipulation to the fourth years. And it's always an experience for me, because they are so fearful of the idea of doing it. And even simple things of actually being able to localize joint segments and actually feel joint motion isn't even really there, let alone the idea of actually doing an actual manipulation or a high velocity thrust. And it's funny to me where I think about what has actually driven that so much. And I was interested, do you actually have any thoughts or opinions on that? Because it's really swung very hard the other way very quickly.
Yes. Well, I think it's very easy to criticize any physical therapy, all of them. And so manual therapy, the basis of it is palpation and dexterity and skills in that regard. So when people have studied this, it hasn't come up that favorably as being by itself a very good way to localize a person's area of concern. And so people take that as, well, it's no good, why do it? And then you only need to give beginners an ounce of that information, because it's friggin' hard to do. It's hard to pick up. It's hard to sense through your fingers. And so if you're not convinced that you're able to learn that skill, it's going to be a lot harder to teach them. And once you don't do that, well, then a whole lot of physical therapy skills go out of your reach quite considerably. All the manual therapy skills, if you don't feel that, if you don't have an understanding of what you're feeling when you put your hands on someone's body, well, then you have a real problem with doing anything when you put your hands on a person's body. And so, it's no wonder then the students are going, minute 5-6 upslope in the cervical spine. Well, I don't even know. Well, that's the other thing. The anatomy skills are probably not as good as they should be. And it's kind of insidious to an extent. But it is a challenge. I hear this. I don't teach the entry-level programs. I teach the postgraduate programs. And most people that come along to improve all their skills, not just exercise or that. And so the undergrads in some areas, they're having some similar problems. I'm hearing from staff at meetings that they're having this conundrum of how to manage this. And students these days, they're different humans than what they were 10, 20 years ago, quite different. And I think COVID really shook everyone all up as well. So, we're dealing with a bit of just the way people feel about themselves and their confidence levels and all that is probably the opposite to what you want healers to feel or be like.
And the other big shift I see now, and I mean, we can look at this for better or worse, but I feel like there is an over-intellectualization of supporting everything that you do. And and social media is certainly guilty of this as well, because you have certain voices who will tell you about all the research and all this. And this is not to suggest that research isn't important. In fact, we're obviously going to talk a bit about your research in the conversation. But I feel like there's sometimes a difference to talk about what the research does or doesn't say versus what actually seems to work clinically. Because as you mentioned, like for a lot of different physical therapies, sometimes the research is pretty scarce, even though actually clinically we may do things because we find that, anecdotally at least, it's very useful. And sometimes there's a bit of a catch up with how research needs to help support what we actually do clinically already. And that's also one of the other big concerns I have of, it's one thing to say something, it's another thing to actually see that in practice and see the actual effect of that particular belief.
I think there's a real need for clinicians to really understand research and evidence, because, and I'm including the social media pundits that are seen as experts, because science, a bit like clinical practice, is a lot about managing uncertainty and the probability of things happening or not happening and being true or not true. And so to be black and white on many things is very fraught. I think that's where issues really raise their heads between clinicians and researchers, and now we've got this other thing in between, is that it's rarely ever black and white, and that if you look at an RCT, and we'll talk about some of my work, the data shows this as a group, but then you've got to take it one step back and really think of how you're going to apply that, what it means to your observations as a clinician in a clinic with a patient. So that gap, I think we're probably closer. I think we're talking about it more than we used to. There used to be a time early in my days where there was a big chasm, and people used to be worse than what they are now. It's just that we didn't have social media to amplify it. I think we're realizing there's a gap, and that there's got to be some goodness from both sides we can use. And we've got to be very careful about black and white, being dogmatic, or really it's either this way or that way, is very difficult to argue for very many things on a logical, scientific grounding. So, yeah.
Well, can you actually elaborate on that? Because, and this is a personal peeve I have, is the term evidence-based practice is used all the time. And most people, when they say evidence-based practice, they're using it synonymously with, is there high-quality research to support this? Which doesn't really fit in with the concept of evidence-based practice. And I'm interested to hear, how do you think we actually need to approach applying research into clinical practice? Because what you're alluding to here is having a bit more nuance about thinking about the results from a study and not actually applying that verbatim to clinical practice.
Yeah, the clinician needs to know more about research and the fundamentals of research to understand a research paper. And I think we do that better now than we did 15, 20 years ago. The problem is with a lot of entry-level programs, people are there to learn to do shit, not to get into the science part of it. That's a classic with physiotherapy. And I think it's a classic with most of the caring professions, where I'm here to get out there and help someone. Yeah, I'm going to make some money, but no one's in this game to fucking become rich. And so generally all there to try to help people. And so, yeah, it's kind of, I think we're better off, but I think the clinician needs to understand research. Researchers need to better understand the clinical context to do the right research. And I think we're getting better at that because we're engaging with clinicians and patients to work up our questions and how we'll go about testing them, and then getting their inputs as we go along. So we're getting better at that from the research perspective. And of course, as you said, evidence-based practice isn't research. Evidence-based practice is you and the patient and how you bring in research into that interaction, realizing that the interaction you're dealing with now is very fraught with bias. An observation of a change over time does not mean a treatment effect. And that's why we have randomized clinical trials. But then randomized clinical trials are group effects. We don't have individual effects in that. They're group effects. On the pure basis that randomization is all about, you can exchange people between groups. So fundamentally, that's about group effects. And so the navigation between the two is the challenge, and to understand what you're observing and to understand the research to how you might nuance and might go about managing your patient differently. I think one of the biggest problems with schools of manual therapy is that the explanations they come up for why things might change when they're treating people are not without basis. They're kind of plucked out of the air. They're plausibly, you can make up a little story, and that's good. You've got to think of why this might work. But to stand hard on those grounds and fight on those grounds, you're going to lose because it's problematic. And I think that's one of the reasons manual therapy is copping a hammering, is because of that, is because we're moving this joint this much with a Mulligan glide, and that's making him move better because it was subluxed or whatever, the positional fault hypothesis. Well, there's no evidence for it. It's very hard to test that hypothesis anyway, which is a problem. So then if you make that story and that's your story, well, it's easy to shoot down from the other angle. So there's kind of this mechanistic thing that both sides can pick on very strongly. Well, basic researchers and people that don't like a treatment can go to very strongly. When we look at a lot of physical therapies, there's moderate to small effects generally across most of them, including exercise. And so that's the group-based data. And so that means that, there's some people that get big effects and some people that get no effects. Now, if they're significantly statistically, it means that, you're not going to have no effect or harm. You're in that realm of it's going to be somewhat better, but it could be a range of better. And so understanding that the confidence and the uncertainty there is probably what clinicians need to feel more comfortable with. Certainly, well, I don't know, I can't say this. Clinicians deal with uncertainty in clinic in a number of ways. We all want to control our lot in life, and so we build stories and narratives that are economical for us to use with patients. Patients keep paying, they keep coming back. So it's a positive feedback loop until someone on social media says that's crap. And then you start schisms coming in, and then you're shaken a bit. So it's an interesting game. I think it's very interesting. I don't have an answer.
No.
Don't be looking for me for answers, but I think the challenge is that gap between what the research is showing and what you're observing in clinic, and understanding the pros and cons of both sides of the argument helps you navigate better. And it's all a good clinician is someone that can reflect backwards on the encounter with the evidence in mind to then moderate or modulate their thinking going forward and how they will develop as a clinician.
Yeah, and it's funny you say that because I think sometimes people underestimate some of the human psychology and like the things that you alluded to, you mentioned, the certainty.
Yep.
And I think humans like to deal in absolutes too. It's either good or it's bad. And the reality is you could have two patients who have very similar presentations and diagnosis, but have very different responses to a particular intervention. Yeah. And again, like there's part of the nuance within research itself because it's about getting a group average. It doesn't necessarily give you an indication of the individual response. And there's probably actually a good segue into some of the research you've done into lateral elbow pain, because I know for me clinically, I see a lot of variation in the response people have to different interventions from lateral elbow pain, and particularly like the prognosis. And so that's probably a good question to start. Why do we actually see, well, maybe we even start with what is lateral elbow pain? And why do we actually see so much variation in the prognosis of someone that presents with lateral elbow pain?
So lateral elbow pain is pretty broad, although it's specific to the outside of the elbow. Predominantly, if you're looking at someone that's got an insidious onset, no injury mechanism, they haven't reached out and grabbed something in that, we're probably looking at some tendinopathy. And as long as they're past the growth phase, we're looking at some tendinopathy or later on some osteoarthritis and tendinopathy of the radiohumeral joint, etc. So acute injuries, you've got to look at ligaments and stuff. Obvious injuries or these insidious onset things, we're probably looking at a tendinopathy. You've got some differentials which I don't think are that hard to find, but you've got radial nerve entrapment and you've got some radial head, humeroradial issues, which osteoarthritis and just injury previous injuries and stuff like that. But generally, we're looking at tendinopathies, and sometimes they're ruptures, and those people normally present with more severe pain and don't respond. And so, so probably I'd say commonest cause, lateral elbow tendinopathy. Then you're digging down into osteoarthritis. As a young kid, you might have some issues with the growth plate there. You might have radiohumeral joint ligamentous problems if they're now getting into pitches and stuff like that, which are putting a lot of torque through the elbow. And that's kind of common, less common, and then not to be missed would be, more acute fractures and stuff like that. I've left out in less common, but something you need to check as a clinician is referral from the cervical spine, the somatic referral, as well as radiculopathy. Radiculopathy is really not that hard to spot, but somatic referral is something that probably is more in this case than there is for lower limb tendinopathy, something you might need to consider if someone's not progressing. So lateral elbow pain, I'd be thinking, you come to me, you say, got pain on the lateral side of the elbow. It's pretty localized to the lateral epicondyle, not much spread at all. It doesn't go into the fingers, doesn't come up the arm. My first thought is lateral elbow tendinopathy or lateral epicondylalgia. And, I'd be expecting you to be painful and weak on gripping. Some tests you can do will be pain provocative, palpations, pain provocative over the side of the common extensor origin. In that case, you'd have a working hypothesis of tennis elbow or lateral elbow tendinopathy.
Well, let's focus a bit more on people that present with, say, an insidious onset of lateral elbow pain, more like the lateral epicondylalgia, because typically I think they present much more with more complexity and uncertainty as opposed to some type of acute traumatic type injury, which is perhaps easier to diagnose.
Yep.
When we think about different subclassifications, the two common ones I think about is the athlete, and you mentioned, like, say, someone who's a thrower, or I guess a good example is a tennis player, versus someone who's in the general population.
Yeah.
But they may present with, again, much more localized pain. It's related to tendon changes, usually the extensor carpi radialis. Even at a cellular level, are they, in terms of the actual pathophysiology, are they different between that more athletic population versus the general population? Or do we actually even have research to look at that? Because I often find that they can, although they might be considered the same diagnosis, may have very different management plans.
Yeah. Yes. Okay. So I'm not too sure there is much data to say why they're different down at the cellular level. So I don't think we can say there. We do know that people that do repetitive manual tasks, tennis is one of them, they tend to be prognostically more worse or harder to get better. It's a prognostic risk factor. It's a prognostic factor for poor outcome if you work manual tasks, things where you're doing anything that involves gripping, lifting, screwing, things of your hands. So repetitive manual tasks or heavy loads is a prognostic factor for poor outcome. So the difference between a sportsman and a worker, depends on their motivation for why they're doing what they're doing. So now you come into other factors, workers' compensation versus et cetera, et cetera. So if you take them aside, there should be no difference between the worker that's doing repetitive manual tasks and a tennis elbow player if they both come, positively engaged in managing their workload, understanding the condition, and then developing capacity and resilience to cope with their workload, and have an ability, in the early stage, maybe to moderate or change the way they're doing things. So there shouldn't be a lot of difference once you take away the context. Workers' comp, low job control, low satisfaction at work. You can think of a meat processor worker in bloody cold, wet, getting up at 5 o'clock in the morning in Melbourne and it's sleeting and -2 going along. It's bloody cold inside those rooms, opposed to the tennis player that's going down to Rod Laver Arena and mixing it with
paying plenty of money to do it. Yes.
Yeah. So Yeah, and getting paid a lot more money to do it, and has probably a feeling of, of agency, of self-control over things. They are going to be different. And we had this model, Coombs, Attell, and Jost. We wrote this paper where, if people have got those kind of factors, you are thinking that they're in the more prognostically worse off characteristic, and so you need to do more with them. You need to be upfront earlier, proactively managing those things. So, that would be one of the differences, I'd think, between the categories that you mentioned. Most of the work I've done has been on the middle-aged person that comes into your clinic. Some of them will be the workers, some of them do play tennis or golf. So, it's a mix of people that you'd see in your clinic, but none of them are professional athletes that in our research projects. Some are professional workers because we've had a range of self-employed people, carpenters, builders, and that have come through our studies because they're bereft with what they should do and have decided to be randomized into one of our groups. Well,
I was going to say, if someone presents with lateral epicondylalgia, do you expect it to be like most tendinopathies, like I'm thinking of the lower limb, where the pain is still very localized? Because I know there has been discussion about spreading pain, and I know there's been discussion about things like central sensitization, but that seems to be more prevalent in the upper limb to the lower limb. What are your thoughts on this? Yeah. Do you expect it to still be localized? If it does spread, why do we see it more in the upper limb versus the lower limb? Are there some explanations for this?
So I wouldn't. So there's a number of things to unpack there. I wouldn't. So I would still be very wary of anyone that comes to your practice that's got lateral elbow pain that spreads anywhere past a hand's width down the forearm. Anything that's going towards the wrist and fingers, I'm thinking is not. It might be lateral elbow tendinopathy, but it's definitely something else.
Yes.
So okay. I'm still thinking that, let's go apples with apples. Lateral elbow tendinopathy purely is localized with not much spread, just like it would be anywhere else. That's one thing. The other thing that you brought up is the sensitization thing. It is evidence that when you take some of the quantitative sensory tests in the lab, that the upper limb tendinopathies tend to have more central sensitization or more manifestation of that. In other words, you will find hyperalgesia on the other side and the distal sides, which we haven't really found in a number of studies we've done and others in patellar or Achilles tendinopathy. It's interestingly that it might be this case in gluteal tendinopathy that you get some of that sensitization. So that's more like tennis elbow and rotator cuff than it is. Those tendons are more like that than they are like the big, thick patella and Achilles tendons. So that's the sensitization, the spreading sensitization. People sometimes want to equate that to spreading pain. Not the same thing, because those people that we've tested in labs that we get increased hyperalgesia on the other side, they don't have any pain on the other side, right?
Yes, okay.
We put them out of study because they've only got unilateral pain. So, so they're two things that need to be unpacked that I think people morph together and get a bit confused. The other thing is that if you do have a patient that comes to you with lateral elbow pain and neck or shoulder pain, even if it's localized or spread, those people are prognostically worse off. We've got data, Vivan, a recent PhD student of ours in the process of publishing this, and Schmidt a long time ago. Prognostically, if you've got someone that's got tennis elbow as their main thing, they've come to you, it's my elbow, I don't want you to see anything else, and you ask them, I get some shoulder pain and I get some neck pain, but their major concern and their major problem is the elbow pain, those people are prognostically worse off. They tend to be harder to get better. They're, after 12 months of following up in RCTs, they're the ones that are not as good as the ones that didn't have that. So, like, there's about three things to unpack in that, and it's all to do with areas of pain. And so localization, central sensitization or sensitization in distal sites. And then there's this thing of concomitant areas of pain, which may involve some spread. How do you define spread? But they're definitely in different areas of the body. So those three things I think we need to unpack. And when you talk about prognosis, that's where I would think if someone's got a local pain, none of the other stuff, not sensitized the other side, I'm on a winner there. I think that's going to get better pretty quick. And in fact, I may not need to do much with that person, but if they start saying they've got some other pains, if you're picking up central sensitization finds, then you've probably got to be a bit cleverer in how you approach that person, because I think you can make them worse, apart from trying to make them better. I think if you provoke them, if you're really aggressive with them, especially lateral elbow pain patients, you are likely to just ramp things up. You've just got to be a bit sensible about modulating the nervous system in those people.
With that in mind, something that you hear a lot about with tendinopathies in general is maintaining some mechanical load. Though, anecdotally, and tell me if you disagree with this, it does seem that, particularly for a lot of upper limb tendinopathies, they actually do seem to respond quite well to unloading. And I think particularly with tendon issues around the wrist, you'll often see hand therapists will actually put them in some type of, and I wonder if there's actually sometimes indications to do that for lateral epicondylalgia as well.
I have a sports-centric approach to this, and that is you keep them active and deload the local area to the minimalist extent. So yes, you might. So with tennis elbow, let's stick with that area there. Our wait and see approach, or everyone gets this, is we tell them how to grip and grab and pick things up that are less pain provocative. And the simplest thing is if you pick something up with your in a pronated position, you're going to be worse off. Now, bright patients that come in that have worked it out themselves are a lot easier to get better. Some people just haven't worked it out, that you can pick up a real heavy thing if you've got your hands supinated and don't grip as hard. So there are ways in which you can load the area, but not provocatively. So we give the thing is like, not over 2 or 3 if you're going to provoke pain at the time, afterwards, and the next day. If we're doing specific exercise, we sometimes allow that to go to 5, as long as immediately afterwards it's back to 2. Why do we pick 2? Well, 1 to 2 out of 10 on a pain numerical rating scale is error. Like you kind of, 1 is nothing. I mean, a change of 1, I don't believe. A change of 2, I'm going, okay, this might be error, plus maybe we're getting in the right direction. Over 2, I'm thinking yes. So I'm thinking 2 is nothing. So that's why I think it's 2. It's like, okay, really that's within error. 3, 4, 5. Now we've probably got a pain that might be more than error. And so now definitely over 5, you're probably dealing with something that's real, not within error. And I'm not saying it's in their brain or they're making it up. It's just that measure. I mean, I've had a lot of chronic and persistent and acute pains. That 0 to 10 scale is not easy to apply, believe you me. I've had patients tell me it's not easy, and I understand from a patient perspective. So, yes, deload. So there's a commonality of keeping them loaded to the extent that doesn't provoke it. And I think that's the case. Where it differs upper limb is that in the lower limb, it seems you can provoke a lot more. So Achilles and patellar tendon don't seem to mind being provoked to the 5 mark. Whereas with the elbow, there's not many people that you provoke to that level that aren't really ramped up.
It's funny, you mentioned about the digital analog scale. I feel like actually in Australia, people are very adverse to give you numbers. Actually, the amount of times I ask people for 0 to 10, they go, "Oh, it's bad." I'm like, "Well, could you give a number?" And they're like, "Oh, it's really bad." Okay, but it's very funny though too. The other thing I think of is, I think I mentioned to you via email, I'm actually currently doing a 3-year training program in this method called fascial manipulation, based out of Italy.
Okay.
And there's a group of people from all around the world, and we often have discussions about cultural variations on people's VAS. And I won't mention any countries, but certainly in Europe, there's very strong beliefs around certain countries having a much lower threshold or higher threshold than others.
Well, I'm Italian, and I'll tell you, we'll rate high, and the Scandinavians will rate, the Dutch will rate, they've got to be dying before they rate 2 out of 10, whereas the Italians are 10 out of 10 before they've got an ache. Yeah.
Well, that's what the Europeans over there tell me the exact same thing, including the Italians themselves.
Oh, yeah. Very expressive, the Italians.
Is there a role for manual therapy for tennis elbow?
So, this is what we researched. So I would say yes. With the caveat, our research was we did MWMs with exercise. Yes. MWMs at the elbow can be done by the patient. So pretty soon after the clinicians worked out, yes, this is a good MWM. In other words, you relieve pain quite a bit, and it's related to their gripping. The MWMs are with grip. So we did a combination, I think 6 visits over 8 weeks, or was it 8 visits over 6 weeks? And there's papers that I could give you that you can put up on your site. But basically, that speeds up the rate of recovery by about twice compared to wait and see. And wait and see is just, like I said before, explain to the patient what the condition is, that it's nothing really sinister. It does tend to get better. These are some things you do need to keep moving. If you immobilize it, it's going to go backwards. You do, but don't really provoke it, and just gradually challenge yourself. So that's wait and see. And wait and see, by about 6 months, you've got 60-70% of people saying they're better. Now, what the trajectory is for MWMs and exercise is that doubles the rate at which they get better in that first 6 to 12 weeks. And so, for that reason, I think MWMs and exercise, there's evidence of. We've got 2 studies that show it quite strongly. And it's as good as corticosteroid injection at 3-6 weeks, but steroid injections, like at about 6 months, are about lower than 50% success rate. So, and there's about 5 times the recurrence rate. So, MWM exercise, good as steroid injection in the first 3 to 6 weeks, if it works, the MWMs. And twice as good as wait and see. By 12 months, steroid injections are still outside this, but the wait and see and physio, 80 to 90% of them are saying they're better. So the prognosis for tennis elbow patients are going to a trial that at the minimalist get told about their condition and how to manage it themselves. 80 to 90% are going to be better, going to say I'm improved or much improved at the end of it. So the prognosis is generally good. I encourage people to say it. Now, when isn't it good? Well, if they've had the condition more than 12 months, most of the people that go into our studies, their median pain duration is less than 3 months. So it's earlier stages. But if someone's come to you and they've had a ring of treatment and it's gone on for more than 12 months, that's in a prognostically worse category. So you don't expect those to get better. You shouldn't be telling them to get better in 12 months because they've already had a shitload of pain.
Why do you think that's relevant? Why is the duration an indicator of their response to something like mobilization with movement?
Well, it may. Okay. I would not tell someone that's come to me that's had 2 years of pain, had a lot of treatments, hasn't had MWMs, that they may not respond to MWMs. That's not. But what I wouldn't say to them, so compared to someone that comes to me 6-8 weeks afterwards, I would say, look, your pains, and there's a few other measures I'll bring in here, but your pain is prognostically good. We don't need to do much. In fact, I can tell you how to manage it yourself if that's all you want to do. And at 12 months, I'm 90% sure you're going to be better. So that's a different prognostic outlook I'm going to give him to the guy that's come to you 2 years. I'm not going to be saying, manage it yourself, and in 12 months you're going to be better. I'm going to be saying, we've got a little bit of a thing to work through here. It's going to take us a few sessions. I can tell you within 2 or 3 sessions whether this manual therapy technique is going to help you at all, and you'll be able to tell me actually because it's relies on you. And then we're going to go about problem solving the situation. Something else I'd put on that besides duration is the patient-rated tennis evaluation thing. A score over about 50 out of 100 puts them into that category that I need to work hard on. Anything under about 30 out of 100, I'm going, a wait-and-see approach is probably going to be good enough for you. And so the patient-rated tenderness evaluation, I bring this in pretty early because duration is not a prognostic factor. So although I said what I said before, the nuance was as I explained it, as how I'd explained to the patient what I'm expecting of them, right? That's different. So all the studies that look at prognostic factors, how long you've had the condition is not a prognostic factor if you follow them up for 12 months. So that's a nuance in that. That's interesting. So the patient-rated tenderness evaluation is a score that if I leave your listeners and you with nothing else, is the one, apart from pain-free grip strength, the other thing that you should measure a patient with tennis elbow is patient-rated tenderness evaluation. It's a 15-item rating scale. The first 5 are pain numerical rating scales. The last 10 are patient-specific function scales, but they're not patient-specific. They're like quite specified 10 activities, 0 to 10, and basically you get a score out of 100, and that, like higher is worse. So anything over 53, 54, you're looking at someone that's going to take a lot more work than someone that's under 33. And so the people I do MWM with is, and quite bullishly, is anyone over the 33 mark. If they're getting up to the 54, I'm going to have to be very clever. I'm going to have to look at referred pain or somatic referral. I'm going to look at the neck. I'm going to have to look at all their job work factors, their psychological factors. I might need to encourage them medicine. And I'm going to negotiate probably a 6 to 12 week period. I won't be treating for that long, but over which we're going to track them and try some things. They're no better after that. They need imaging. That's when I do imaging because they may have something else going on. I do the ligament stability test and palpate to kind of problem solve early on if it's not really tennis elbow. But I'm assuming that they're testing positively for tennis elbow. Yeah. So I hate to kind of take you on a big ramble there, but kind of there's a bit to unpack there. And that's probably what I mean about nuance of the research. And I've immersed myself in that research because I had PhD students doing it. We've got a couple of big studies that we've published and we've been challenged on it. So I've had a lot of time to think about it. And it's a very reasonably simple condition compared to some of the other ones around. So like low back pain. And so that nuance is how I would explain what clinicians need to become good at to marry the two in clinical practice. And it's not easy.
Speaking of that nuance, because you've highlighted that you have done some research to show the efficacy of something like mobilization with movements. So that highlights that perhaps manual therapy does have a role here. Now, do you think that the mobilization with movement technique is unique in the stimulus that it applies to help tennis elbow pain, or do you think it's more reflective of just a manual therapy technique in general to the area has a positive effect?
So I think, so frictions don't seem to have the same effect. That's been studied. Okay. So frictions don't have the same effect. The mechanisms through which a lot of manual therapy works is not local peripheral tissue in terms of connective tissue, because we know that takes, unless you're doing continuous passive mobilization for weeks continuously, no rest, realistically you're not going to get the loads you need to get connective tissue changes. So we appreciate that, and you're not breaking down cross fibers and that, because again, we don't do it long enough, and et cetera, et cetera. So I think we're dealing more with physiological, probably neural, central nervous system changes, either locally or centrally, like the whole gamut, peripheral and central. Now, the manual therapy techniques that I've studied are ones which do large afferent inputs, minimal pain provocation. Those, a number of studies have shown, are non-opioid in nature. And likely, and there's been a rat study that kind of goes along with this, likely invoke descending pain inhibitory pathways from the periaqueductal gray and modulate it around the brainstem. Now, there's nothing special about manual therapy. That pathway is as old as the hills in humans. It's homeostasis. It's like fight or flight recuperation. And so I think what's happened with manual therapy is that in an uncanny way, we found a stimulus which can modulate or trigger a response to the degree that it's helpful. And I think that's what happens. Now, TENS does a similar type of thing. And that's the gating mechanism, which can happen. It has a descending influence on it as well. So, so is it specific? What do you mean by specific? It evokes a response which is innate in the human. And I dare say certain exercise does that as well. Now, the system I talked about is a non-opioid system. There are opioid responses as well. Now, if I did friction massage or I did a technique which is really strong, a Mills Manip or, like some of those hard things, they're probably opioid mediated responses, and they work differently. And you can do with TENS, you can have non-opioid and opioid mediated responses depending on the parameters you engender. So there is a bit of specificity to it, but it's not like this. It's not like drug X does a coenzyme XY and it only does that and nothing else does it.
Yes.
It's kind of like there's a system in the humans, and these stimuli stimulate it. Now you can stimulate it from a number of different ways. So that's my take on it, and in a very just in a talk through fashion. I mean, I've got slides and it's written and a bit more complex than that, but essentially, yeah.
Well, actually, there's two things I was going to say, and don't want to go too off topic at the moment, but you talk about changing the connective tissue. A lot of the work that's coming out of the Fascial Manipulation Institute that I'm doing this course with, because they do a lot of research themselves, is actually about changing the loose connective tissue between the layers of fascia. That seems to be much more adaptable and responsive to sort of mechanical stimulus, as opposed to like changing the actual collagen density or orientation. But the reason why I asked the question too about the mobilizations with movements, because it makes you think, can we start to transfer some of the findings from your studies into other areas of the body, whether we're thinking about rotator cuff tendinopathy or obviously lower limb tendinopathies? But then it makes me think, can you actually apply mobilization with movements to that area? And is it actually going to have a similar response? Because obviously there's unique anatomy to lateral elbow pain and the radiohumeral joint.
Yeah, I think the short answer is no. The longer answer is suck and see. And the suck and see is basically, if you do, let's just do a simple thing. You've got a rotator cuff related shoulder pain. The diagnosis there is just a fucking nightmare to start off with. But let's just say,
yes,
assuming it's a tendinopathy, and you do a bit of a glide and they move a lot more freer. They can do it with weight before they couldn't do it with weight. Well, what's the harm in using that as a treatment stimulus, as long as you don't over pathologize it and make bullshit excuses for it and get them moving?
I was going to say, give them a window to apply mechanical load. Yeah.
The problem is, if you make a lot of bullshit story about it and you make them believe that you're the only one that can do it for them and they can't do it themselves, you're just invoking a whole lot of externalization, which is probably not helpful for these kind of conditions, I think. I've thought about it with other areas, and like we did a study on gluteal tendinopathy, and we thought about manual therapy. We sat around the group of experts that I engaged, and we wouldn't do it clinically. We wouldn't even suck and see. Like we sat there and really asked hard questions. What are the things we could do? All right, how many of you got a patient now would do it? No. What happens if 6 months down the track and when better you do it? Oh, I'd be reevaluating the diagnosis and blah blah, a whole lot of other stuff before doing it. So it seems to be a little bit unique in this. So maybe the reason why I went there is I did some Mulligan courses, and in clinic, about the only thing that I could get to work really well was this.
Yes.
Was this area?
Yeah.
Okay. The shoulder was hit and miss, a lot more hit and miss, and I think the diagnosis and the getting a good feeling of what's happening in shoulders is more challenging than at the elbow.
Yes.
Now, can I step back a bit? And you can tell me if I answered that or not. Going back to your connective tissue massage or the extracellular matrix is pivotal to muscle and I think tendon homeostasis, injury, and rehab. And I would not discredit manual therapy of whatever regard having some influence on extracellular matrix, which is the stuff in between the collagen fibers and not the cells. And so that, I think physically, well, it is actually quite strongly, and the cells quite strongly manipulated through physical stimuli.
Yes.
And so to the extent that it's pain relieving or it changes connective tissue synthesis and then strength, I don't know. I think you'd have to have long enough stimuli periods to get there, but that's another thing. But the extracellular matrix is what I'd be thinking about there. And
well, and look, we can talk about as much as actually I guess we like, but and this is going into this concept of how does fascia influence the neuromuscular system, and part of this is about understanding that within the deep fascia, so like the aponeurotic fascia or the epimysium. It's very highly innervated in free nerve endings that itself can actually be nociceptive in nature because they're polymodal, but they're also very mechanoreceptive and seem to have a lot of input for proprioception and influence sensory motor control. And actually, I don't know if you've read the study that Paul Hodges was involved in. He did a publication a couple of years ago. I think it was with David Klein and that group, but they did it in collaboration with Carla Stecco, who she is the head of anatomy at Padova University in Italy, and her brother are the ones that run the Fascial Manipulation Institute. And it was looking at changes to the connective tissue within the multifidus in their sheep model when you cause a disc lesion. And they showed an increase in fibrosis that specifically happens in the perimysium, and that affects the function of the muscle spindles because the muscle spindles are located in the perimysium. And that was sort of to be suggested about one of the things that you see with changes in EMG behavior because of the altered effect of getting a bit technical here, but like the gamma efferent not allowing the intrafusal fibers to cause the spirals to function properly, cause inhibitory feedback, alters alpha motor neuron recruitment. And that's sort of a nutshell. And again, this is obviously something I'm particularly interested in because I'm obviously learning a lot about it. And it's obviously sparked my interest too to think about, do we need to be a bit more nuanced with manual therapy about thinking about different types of techniques and the influence that it has on the periphery, and perhaps some of the peripheral changes we don't appreciate because I guess the way that we have quantified changes within the periphery haven't maybe picked up some of the things that may be happening.
The challenge is measuring the shit.
Of course,
It's like, so it's a very hard hypothesis to discredit because there isn't an easy way to measure it. And that's
for sure.
That is something that's, again, understanding that is important for both those that promote it and knock it.
Absolutely.
That's the, Paul and Dave, Paul's a long-term collaborator with me. We work in the same place, and
yes.
Dave's up-and-coming gun.
Yeah, well, no, I've been really impressed with some of the work that they're doing, and I guess for me too, like I'm very interested and have been for a while about what is this connective tissue and fascia? Like, why didn't we really learn about it? Because I think the whole musculoskeletal system itself and some of the models we have for muscle tendon behavior don't actually take it into consideration. And so I don't know, I feel like it's one piece of the puzzle that may help to inform us a bit better about certain types of presentations.
Fascia is such an integral part of the musculoskeletal system. I mean, the lateral fascia of the thigh, I mean, the femur needs it to be good and stable. So it's kind of like it. And I dissected it for my sports masters, the lateral band of the thigh, and man, it's thick. It is hard. It is a real beast of a thing.
Well, I mean, all the aponeurotic fascia in general, like Carla has done a lot of research of looking at the deep fascia, and it's quite amazing actually how anatomists dissect it because there's so much intimate connections between the aponeurotic fascia to the underlying muscle. In fact, a lot of muscles actually originate from it. That's why we kind of get pinnated muscle. So they've done a great job of getting rid of it to try and make us think, oh, well, that's not really relevant. And I think that has a big influence on us clinicians too when you're in the anatomy lab and you see, it's beautiful origin insertion of this particular muscle. And anyway, that's not to get too sidetracked here.
there is, there are some people like the pain people that are gone, pain the brain and all that stuff and psychosocial. But I think there's a real need for physical therapists to learn the physics of the human body, like the anatomy and the structures and all that. Okay, you can hypothesize things happen when you do a certain therapy, and it's hard to prove or disprove.
Yes.
Probably easier to disprove, but not on grounds of evidence. And so, so it's something that I think maybe our programs have dwindled down because of the resource requirements for anatomy labs. Now, I dissected things in my undergraduate and postgraduate things, but I don't think they do that anymore.
No, look, I'm again we did some. I went to Melbourne Uni and we still did some of that, but it's very expensive.
It's very hard to do, and these days we have a lot more respect for the dead.
Yes, and well, actually, I think the other thing that I've found interesting too is what happens to particularly the connective tissue when you embalm a cadaver.
Yes.
Which I mean, because interestingly, over in the University of Padua, they actually have an exception to do cadaveric dissections to unembalmed specimens. And you can start to really appreciate the different sublayers of the aponeurotic fascia and see that gliding much more evident as opposed to the embalmed specimens where they essentially cause it to glue and get them all stuck.
My first paper is I'm going to frame it. I should have framed it ages ago. Is with Lance Toomey on the lumbar spine. They were on unembalmed spines, and I didn't look at the structure, but I looked at how they moved and responded to loads, and it was quite an eye opener.
Yeah, and look, it's something that I see that we're seeing a shift where some of the basic sciences and thinking about first principles I feel like as a profession, perhaps we're moving away from.
Yeah.
And my only concern with that is it sort of limits your ability to apply clinical reasoning. It very much just becomes this protocol-driven approach to how we treat problems.
Yeah. It is. That is a negative. That is a poorly applied evidence-based practice approach. It's problematic on a number of levels. Yes. Yeah. You need critical thinking and you need reflection.
Yes, well, I feel like there's a bit of a paradox sometimes because at university they're always like, we've got to think about clinical reasoning, problem solving. But then when you try to be nuanced with your approach, it's like, well, where's the evidence for that?
Yeah.
And so I don't know. I feel like you can't win at times.
It's it's bloody challenging.
Yes.
Yeah.
Well, you mentioned, Bill, that soon to be going to somewhat retirement. You're going from into an emeritus professor position, and as you were mentioning off air, that obviously gives you a lot more flexibility to really focus on your research. What are you working on now? Where do you want to go with what you focus on as you go in the next chapter of your life?
So I've done work in patellofemoral pain and ankle OA. So there's a couple of gun associate professors, young ones. One was my PhD student. The other one's a colleague of mine, Michelle Smith and Natalie Collins. They've got MRF.
Which I'm actually having Natalie on straight after this.
Excellent. So
yes.
So I'm helping out with them on some of their projects and their PhD students. There might not come anything of this, but we're applying for. There's a quantum grant here in Queensland. It's gone big time, and so we're looking at how. And Paul Hodges and really bright people are leading this. I'm one of the team. We're looking at whether we can use magnets and quantum physics to measure muscles, because there might be some advantages that overcome some of the EMG disadvantages. And so that's one area that is on the radar, is on the books that we're looking at. And the other big thing that I'm going to spend a lot more time on with Vienna and some of the others is single case N of 1 study designs, which I believe are a way in which clinical practice could possibly go, seeing if we can get some funding to apply them. And I'm going to take a little bit of time off, visit my grandkids around the world, and then come back and we'll probably see how enthusiastic I am, but we'll probably get stuck into that.
Yeah, great. It's always interesting to hear, Bill, about what people we talk to like to do outside of their professional practice. You know, are you someone who has any particular hobbies or interests that you pursue or are pursuing at the moment?
I'm the opposite to my wife. I don't have that many. My wife's got 1,001, so we've got a big house and it's filled with all her art and weaving and stuff. So I like hitting the trails. I like exercising, and something that I'm wanting to do to kind of it's like I equate it to a physical chess. Physical chess. It's Brazilian jiu-jitsu, which I've just started about 6 months ago.
Oh, yeah, great.
Very stimulating, challenging thinking of strategy and how to move in it. And it taps into the periaqueductal gray and the lower brain stems, which are being choked out and killed most of the time. So I'm doing that as part of my physical fitness and mental fitness, just to stave off the old mental decay, which is inevitable in us oldies. So that's one thing I'm taking. But I love trails. I'm going to do a lot of trail. I've got a couple of kelpie dogs, and we go out in the trails and run up and down creek beds and jump around and stuff.
Yeah, great. Are you someone who is active on things like social media? If people want to follow the research that you're doing, or I like Instagram because I'm a visual person. So I'm Bill Vicenzino on Instagram, and I'm on Twitter at Bill Vicenzino. I think there's an underscore between Bill and Vicenzino on one of those. Yep. I can't imagine there's too many Bill Vicenzinos around, so they should be able to find it. Yeah, there aren't too many Vicenzinos, and we're all generally related, I think. Yeah. Well, look, Bill, thank you very much for coming on. It's been a really interesting discussion. It's always good to get someone like yourself who's actually been through the different evolutions of physiotherapy to be able to reflect on some of the changes that we see, because I think that's something that a lot of particularly young clinicians don't see, where the profession's come and where it's going in, and for better or worse, really. I'd like to thank you for saying I'm old in a very nice way. Thank you very much. Wise, I would say, Bill. Wise. You've done it very well, beyond your years. You've done it very well. Thanks very much for coming on. No, pleasure. And for our listeners, please do like, subscribe, do all those things on YouTube, whatever podcast platform. It really does help us to share our message and reach more viewers.